Dr. Susan Benden is our next speaker. She's Associate Professor and Associate Dean for Faculty Development at the University of Maryland School of Nursing. You may also recognize Susan as the person who teaches the clinical teaching workshops, NSP2 supported program that's offered, twice a year, I believe, right?
Three times a year.
Oh, three now. Oh,
yes.
Great.
Well, thank you, Becky. Hopefully you can view the screen okay?
Yes, looks good.
Great. Well, thank you so much. I'm thrilled to be here. I'm very happy to see so many people here. It's a great morning. So my job here is to talk about connecting the dots in the clinical learning environments. And that's where the students call it in real life. And I had a student tell me the other day that clinical was like real life simulation. So I thought that was a pretty good assessment. So as the name suggests, this track is to help hopefully provide you with some ideas and strategies to help students carefully and compassionately develop their clinical judgment skills in that clinical learning environment. So again, as educators, we have objectives, and this is for today and also for the upcoming year for this track. So we'll talk about some of those barriers that get in the way of helping students apply classroom knowledge in the real clinical setting. We'll consider how reflection fits into clinical learning experiences and not just journaling, but all kinds of reflection throughout the day, throughout the semester. And then outline some strategies to help students build their confidence. And a couple of you have mentioned student confidence this morning, which is such a beautiful thing to see in action. So I love to start off with this. And as Becky mentioned, I am fortunate to lead the NSP2, and thank you, NSP2, grant for developing clinical faculty in Maryland. And I always start off with this tweet. This is a tweet actually from Marilyn Orman, who of course is the editor of Nurse Educator. And this was an editorial she did several years ago, but it's a shout out to clinical faculty. So I always start with this. And she says, to all clinical nurse educators, thank you for guiding students in the clinical setting, preparing them for the realities of practice and helping them develop as professionals. So that's no small charge, is to get students into that reality of practice, trying to apply everything they've learned, keeping it safe, keeping it real, and helping them develop as professionals. So I love this. It's a great editorial. Share with your clinical faculty as the semester gets started. And Dr. Orman and her partner, Dr. Gaberson, call clinical learning where the rubber meets the road. And so in that spirit, again, a shout out to clinical faculty. As part of the grant that Becky mentioned, we do clinical faculty workshops, and I've developed this framework, the 5 R's I call it. And this is kind of how we build the content, and we find that these elements are super relevant to clinical faculty as they're learning to work with students. Many of them are new or novice clinical faculty coming from clinician roles. So we spend time talking about the role of clinical faculty, the responsibilities, again, not only keeping students safe, but helping them learn at the same time, which is a tall order. We talk about resources, again, that reality is we spend a lot of time in there, and this is probably one of my favorite parts, and this is where that storytelling that Kathy mentioned, clinical faculty share incredible questions and stories with each other about the realities of clinical learning. And of course, the relationships between the faculty, the staff, the patients, the administration, et cetera. I always put a little gray slide in there to pause, to think. So Becky just mentioned this book. Thank you, Becky. This is it's a great book. And yes, it's 10 years old, 11 years old, but it's by Benner et al. And, you know, it's talking about a radical transformation in nursing education. And here we are 11 years later. I'd call this a semi-radical transformation. I think we're doing a lot of the things already. I think we have good bones. But these are kind of those points that I think Benner points out. It's a very practical read. It has lots of examples in it. She talks about situated questioning in the clinical setting to help diagnose and guide students' thinking. And questioning is such an important skill for faculty. There's a wonderful study by Phillips in 2017. They created a scenario for clinical nurse educators, 3 scenarios, and the educators generated over 1,300 questions. On analysis, analysis, they found 72% of those questions were at the knowledge or comprehension level, which tells us they're much too low. So that's really a kind of encouragement, motivation for us to learn more about questioning, which we will. She talks about seeking that sense of salience that Becky mentioned, and salience means figuring out what's notable and significant. And students have a hard time doing that sometimes. They have to learn that. In other words, kind of separating the signal from the noise. And they need help to do that. And when that clicks, it's a beautiful thing, that connection. Clinical faculty, if we can drill down to what the learners know and don't know, it gives us a baseline. And I know with 8 students in the clinical group, you got 8 different baselines, but it's a good place to start for each student if we can do that. Some students don't know what they don't know. And sometimes we have to remind students that they do know what they need to know. They just have to pull it from Dr. Martin's Patho-Farm course or some other leadership course, etc. Help them recognize and analyze that cues. That's all through the clinical judgment model. Make sense of them and take it a step farther, take some action on them with our help. And then in red here, it's again, making that connection between having knowledge and using it. I always say knowing how to drive and driving are 2 different things, right? Knowing how to have a difficult conversation with a family and having that conversation are 2 different things. It takes practice. So I recommend the book or even a summary of the book. It's helpful to remind us of those good bones. Of course, the benefits of clinical judgment, students having that, we've heard about that all day. They learn it, they're learning mode by way of success and failure. And I think all my counterparts today have mentioned failure. That's how we learn, right? By trying and trying and trying. Building confidence, and I tell the students all the time, confidence comes by way of competence, and competence comes by way of practice. So get back in there and try and learn. We either succeed or we learn, right? Progression, of course, that's the student's goal, to get out of my course and get to the next course. So progression, patient safety, always, always. And building their role identity. And I love Kathy's question about, what would the nurse do here? If you're thinking like a nurse, step into that a little bit. Each course takes them a little further into that identity. And professionalism, knowing your limits, knowing when you need help, knowing when to ask questions, etc. So that clinical judgment is a wonderful thing. The challenges of developing it. So back to the realities of clinical teaching, there's never enough time in the day, never enough time in the semester. Clinical learning is unpredictable. The classroom or an online or simulation even is somewhat predictable, or skills lab. Clinical, you never know. And clinical can be defined in 1,000 different ways, but it's unpredictable. The patients and clients may not be available depending on the setting. You may be looking for a patient with a chest tube, it's just not always available. Clinical group size, some of our clinical groups have become a little unwieldy because of faculty availability. Some are very small due to site capacity. So some groups are a little large, some are a little small, which is challenging. Every student, again, if you have 8 students in your group, their KSAs, their knowledge, skills, and attitudes all vary. And some are fearful, some are anxious, some are overconfident, some are over or under prepared. And practice is always a piece of the pie too. So that KSA knowledge challenges are always there in trying to help students develop their clinical judgment. Some students have what I call one-way thinking. They've learned that there's one way to do something, and helping them in the realities of clinical practice see that there might be more than one way to safely and carefully achieve a goal. Their readiness. I'm a big fan of talking about readiness, student readiness and preparation and motivation. I also think it's important for us to think as faculty about our own readiness. And I try to take myself out of the equation. I don't want the students to ever worry about which version of myself will show up today. So I try to be prepared and to be ready and to be flexible and open for the day. Diane, I think Dr. Billings mentioned the checklist this morning, and as faculty, sometimes we are beholden to the checklist. We have to help students get those things signed off. Sometimes the best learning happens beside the checklist. And, it's a balance of completing what we need to do to meet the course objectives while taking advantage of those wonderful learning opportunities too. And of course, the students care about their grade and their exams and their class, and we have to connect it to that. Our job is also to connect it to what they've learned and amplify that and verify that. So why do I have a picture of a swamp here? Some of you know, if you're a fan of Donald Schoen, a 20th century educator and thinker, he talked about learning sometimes as being a swampy place. And more specifically, he said there are two kinds of kind of learning situations. There's the hard, high ground. This is what you expect when you go into clinical or classroom or simulation, where the practitioners can solve a problem using the tools they have, their theories, their models, their techniques, the things they've practiced. And then that goes pretty well. And then there are the swampy lowland problems where situations are confusing or messy or not what you expected, or the context is completely different. And then he goes on to say the high ground problems are important. They're usually more easily solvable. The low swampy problems are the ones that really make a difference to the patient or client or community. And I was thinking about that this morning with COVID. We've seen both, right? Setting up a vaccine clinic might be, it's complicated, but it's a kind of a hard, high problem. Getting folks to the vaccination center to take advantage of it, that's a swampy problem, okay? But students engaged in both of those areas can have good learning and develop their judgment. I remember my daughter in her BSN program came home one day from clinical, and I asked her how it went, and she said it was terrible. I said, tell me more. And she said, I didn't get to do anything. My patient was discharged unexpectedly. She said I had to call pharmacy. I had to spend like an hour making sure her meds matched up, had to call social work for a walker. And then her daughter was coming from New Jersey and was late. So I had to do clinical discharge teaching twice. And I said, sounds like you had a great day. It sounds like you had a wonderful day in the swampy lowlands, learning all kinds of clinical judgment, decision-making, et cetera. And so, of course, it took her a while to realize that. She can appreciate that now. But I love to tell students it's not about the Foley. Clinical judgment and decision-making is not about the Foley. It's about these swampy lowland problems. So the good news is that, you know, getting the students out of the swamp, we know to expect the swamp. We know how to make the swamp a little safer, a little bit more appealing to students as in terms of a learning environment. And, you know, Confucius even says there's 3 methods to learn wisdom. And wisdom is that beautiful thing you see experienced nurses do where they walk in, they take a look around, and instantly they've prioritized and made decisions and decided what actions to take. And 3 ways to get there: first, by reflection, which we'll talk about a lot. Second, by imitation, which is role modeling and watching us, good or bad, watching the other staff nurses. And third, by experience, which is that try again, try again. I don't know about bitter, I would say the most challenging, but 3 ways to get to wisdom. And we all know that model where students, it's, again, I love watching students go from data points to make that information, turn that into knowledge, and eventually bring that into the realm of wisdom. And watching their thinking and their judgment evolve like that is a beautiful thing. So I want to give you kind of a peek into what we have planned for the year ahead in terms of clinical learning. And if you have other ideas that I haven't included here, I'd love to hear them. Session A, hopefully in the next, sometime this fall, we'll pick up on that idea of questioning as a strategy to develop clinical judgment. And there's a great quote where it's about leadership, but I think it applies to faculty too. We should be more Yoda and less Superman. So learning to ask those questions and be patient and ask them in a different way and stay in there with students. Session B, I would like to talk about making the most of that pre and post clinical time, that precious time where we can pre-brief, debrief, see what came up during the day, see what salience we can help the students find. And lastly, working with Gen Z learners in the clinical setting. So many of our students already are Gen Z and will only become more so. Certainly not all of them, but it's interesting to think about our next group of learners. And as the learners change, we need to change also to meet their needs. So that's what I have, rather short and sweet. If you have other ideas, again, or comments or questions, I would love to hear from you. And also I'll put a plug in again. Thank you, NSP2, our new grant number 22111. The next clinical faculty workshop is January 18th and 19th. So please send your adjuncts or send yourselves. Love to have you. It's virtual. If you'd like more information about that, let us know as well. So Becky, that's what I have. Thank you very much.
We really appreciate it, Susan. Lots to think about. And I think this is a personal statement from Becky that I think the clinical situation and clinical teaching is the essence, as you say, that Gaberson and Orman have said. It's where the rubber hits the road. I would say most of nursing school takes place in the clinical setting, and we need to know what goes on there, and we need to know how to guide it and make sure our students are learning how to be excellent nurses who can think and who can reason and figure things out. Because as we've all learned in this past year, we are thrown novel situations every single day. We need to have the skills to be able to address novel situations. And that's what clinical judgment is trying to help us do. So thank you so much, Susan. And the upcoming workshops look great. I can't wait to tap in and see what they're doing.